Hello and welcome to this CTSNet interview. I'm absolutely delighted to be here with Professor Nasser Altorki, the man of the moment. We're talking about the CALGB 14053 trial, but I don't like that name. I'd rather call it the Altorki trial. So my name's Joel Dunning. I'm one of the CTSNet editors, and I'm here with Mara as well.
Thank you so much. My name is Mara Antonoff. I'm a thoracic surgeon at MD Anderson in Houston, and I'm thrilled to be here along with Joel Dunning and Nasser Altorki. I'd like to take a moment to formally introduce Dr. Altorki. We're so fortunate to have him here. He's a professor of cardiothoracic surgery and the director of the Division of Thoracic Surgery at New York Presbyterian Weill Cornell Medical Center. And following medical school in Cairo, Dr. Altorki completed his residency in general surgery at the University of Chicago, where he subsequently completed a fellowship in thoracic and cardiovascular surgery. He's an internationally renowned thoracic surgeon with expertise in minimally invasive lung and esophageal surgery. And as mentioned by Joel Dunning, Dr. Altorki presented his landmark results from the CALGB 140503, or the Altorki trial, earlier this month at the World Conference for Lung Cancer in Vienna, sharing with the world that sublobar resection had very similar results to lobectomy for peripheral non-small cell lung cancer tumors with a diameter of 2 centimeters or less. So with this very exciting news, Dr. Altorki, can you please provide a refresher for the audience on the study schema and the inclusion and exclusion criteria for the conduct of this study?
Sure. So before I give you the study schema, I just want to give you the study history, because I'm pretty sure none of us is going to do this again. The concept was proposed to the CALGB steering committee. There was no alliance at the time, the CALGB steering committee, in 2005. And it has to go through the bowels of CALGB and the NCI before they give you their approval. And we got the approval in 2007. In frustration, I complained about this, and I was told to shut up because this was the fastest approval ever. 2 years to get it approved. And then we got it started. I think it was in June of 2007. And the accrual was completed in March of 2017, 10 years. And the trial's sample size was reduced from the original 1,200 patients that was planned. No, we thought we'd follow the pattern of Z30, and as you may recall, Z30 was done, I think, in 3 or 4 years, and we got a 2-year follow-up, and that was when we were done, but that wasn't to be, and so we reduced the sample size, but extended the follow-up period. So from 2017, we could not report it before at least 5 years have elapsed, so really 351 events. And the DSMB, which meets twice a year to review the trial result, decided in their last meeting that it is unlikely that there will be difference in outcome between the 2 arms of the trial. So that's the sort of the historical background, which it took an amazing 17 years to get it from beginning to end, which is why I think we'll never do this again. So the trial was based on 2 centimeter or less in size peripheral tumors that were clinically node negative, but really followed even the paradigm of the lung cancer study group, which is to go in and biopsy at least 3 nodal stations, the major hilar, which are level 10, and 2 mediastinal nodal stations. And if they are negative, then you can, so you're eligible if you're clinically node negative. So you get registered, and then you go to the OR, and if you're on the frozen section, there is no evidence of metastatic disease to the lymph nodes, then you get intraoperatively randomized. And that was a logistical challenge, because intraoperative randomization presents its own logistical difficulties, but I think that makes it a very highly selected group of patients. And that's very important for people to understand. That we decided that the primary endpoint would be disease-free survival, which is defined as recurrence or death from any recurrence of lung cancer or death from any cause. And the secondary endpoints were overall survival, differences in pulmonary functions as measured by spirometry, basically FEV1 and FVC, between baseline and 6 months, comparing the 2 groups, and difference in the recurrence rates.
So
You know,
So, yeah.
presently we sort of stratified the randomization by tumor size in smoking history and cell type. Joel, you were saying something.
Oh yeah, no. Well, we've got 1,000 questions. Just to be clear, could you have pleural invasion? Could the tumor go onto the pleura, or did they have to be parenchymal?
Well, so as you can imagine, we discussed that, and the problem was, how do you determine pleural invasion preoperatively?
Right.
So it's sort of a tough call to make whether or not it actually is through P3, as they say, and intraoperatively the same thing. And in the end, we decided it doesn't really matter. I mean, I think peripheral is peripheral. The important thing is you don't have parietal pleural invasion.
Right.
Yeah, great. So let's talk the results, because this is the golden nuggets, really. So you had brilliant outcome measures. So disease-free survival, 63%, completely the same in the two groups, weren't they? And recurrence equivalent. So talk us through your major outcome measures and just tell us why they are so important.
So as you've already stated, you know, there was no difference in disease-free survival. You know, the longer the trial went, the more comfortable I became with the idea that maybe there is no difference between the groups. But I would not have the faintest clue that the curves would be superimposable, essentially. 65%, I think it was 64% in one arm and 63 and change in the other arm. The curves are inseparable. So that was the primary endpoint, and the stratified hazard ratio there was 1.01, which is really good. The secondary endpoint, and you know, the secondary endpoint was overall survival, and again, here there was no difference, with the overall survival being about 80% in the sublobar resection group and about 79% in the lobar resection group, and the stratified hazard ratio is tantalizingly 0.95, perhaps intimating that maybe sublobar resection is associated with better overall survival, which is kind of interesting given that the Japanese trial had shown that segmentectomy is superior to lobectomy in terms of overall survival. We also showed that the differences in pulmonary functions were small. An absolute difference between arms in FEV1 of about 2%, which was statistically significant, but probably not clinically meaningful. And the recurrence rate, now that was a surprise to me, 30%. I mean, we would think that you take, this is like the earliest of the early lesions, 2 centimeter peripheral, node negative, etc. And here we are with a 30% recurrence rate. About more than half of these recurrences were systemic. So I think that sort of a clarion call for us to understand that additional treatment here is something that we need to look for. Unfortunately, chemotherapy doesn't work very well. We know that from the randomized trials. So the search goes on. I mean, these people continue to be at risk for recurrence.
These are certainly really compelling findings, and I think, you know, we'll talk about a little bit more about how they may change our practices. But before we jump into that, just wanted to ask some clarifying questions for you regarding the process for the frozen sections. You mentioned the lymph nodes and the stations that needed to be sampled. And can you tell us about the need for a frozen section on the primary specimen in terms of if it was a segmentectomy, getting a certain margin of resection on the bronchial margin or any parenchymal margins that needed to be examined intraoperatively beyond just the lymph nodes?
Well, there was really no mandate of telling the surgeon. We mandated that the frozen section be done on the lymph nodes to verify that they're node negative. We did not say that the surgeon should have a frozen section on the margin, but we said that if the surgeon feels that the margin is suboptimal, they can do one of three things. One, they can do an additional wedge. It's not sometimes the easiest thing to do. They can convert to a segment if they started with a lobe, or they can convert to a lobe. They should do whatever is necessary in the interest of the patient. We asked that the surgeon record the length of the margin. The recommendation was that at least be the size of the primary tumor. And then the discussion was, well, when do you measure the margin? Is it measured in the inflated lung, in the deflated lung? So these are all little nuances that we would have to tease out from some of the data that we have. And we have a lot of the data on the margins from the surgeons, but there are more of it in the pathology reports, and we hope to have something about the correlation of the margin with recurrences. I doubt that there will be a correlation with survival given the nature of the curves there.
Should we expect to see data coming out in the future related to the comparison between the segmentectomy and the wedge resections?
Definitely, because I know there's a lot of interest in that. My thoughts were, there's probably if I were just a guessing man, and I don't know the results, so I don't want to spill the beans too early, but given the overlap of the curves and the fact that 60% of the patients had a wedge resection, segmentectomy must perform spectacularly to make up for any deficit in wedges. My guess is that they're probably similar. But we'll see what the data are, and we're shooting to have something presented at the AATS in Los Angeles. And I expect that Joel would be there.
Front and center, I certainly will. So let me challenge you a little tiny bit. My oncologist was so excited about your trial. He said, look at this, wedges are the same as lobes and SBRT is the same as a wedge. So you've just proven that SBRT is the same as a lobe. How do we answer that?
Well, we are, I am not aware that there was an arm in the trial that included SBRT. So, the median follow-up in this trial is 7 years. And I would like to see data in the SBRT world that shows the median follow-up is 7 years. And I would like to see a rigid accounting for recurrences and death. And I haven't seen that yet. And, if that is the case, then yeah, glory be to God. SBRT and wedges are the same, but I haven't seen the data, and we tried 2 randomized trials and they flunked spectacularly.
Yeah, no, well said, absolutely. And I think we can quite easily put that to bed because of the rigor of your study with the amazing N1 exclusion and margins and the rigor that you've put. So let's put this into context. Obviously, we've got the Japanese trial and your trial. I mean, I'd love to see a meta-analysis of both, of course, but how do you feel they both fit together? Do you think they really both complement each other, or how do you fit with the Japanese trial?
I do think that it is that it is really reassuring that we have 2 relatively large trials. The Japanese trial got almost 1.5 times our size, and that they all are pointing in the same direction. That's good to know. I think our purpose from our trial was to put wedge resections to the test. It's interesting that we've all have it ingrained in us that wedges are bad cancer operations. I grew up in an environment in which it would be heresy to challenge lung cancer study group trial. And but then, Joel, when we look at the databases, whether it's the STS database or the European database or the National Cancer database, and you look at what people actually do, they do different from what they say. So, and I think it is important if we can target those early lesions, those screen detected lesions, incidentally detected lesions, with an operation that has less than 1% mortality. Why not? I mean, I think that sort of expands the horizon of who would be eligible for surgical treatment. Now, there would be times when you can do a superior segmentectomy or an anterior segment or an upper lingular sparing segment or whatever. But, I think where we get in a bit of a pickle is in the complex segmentectomies of the lower lobe, where, yes, you can do it, and it would require special expertise to do that. But our Japanese friends have already shown that that is associated with higher rates of adverse events and increased air leaks and so forth. So you'd have to balance that against it to some extent.
It's great perspective. I'm curious to ask you, as we think about the results of your trial, so many of us are already trying to kind of visualize how we're going to incorporate these results into our own practices. And one of the questions that comes to mind for me is, in a setting where the majority of our patients may already have an EBUS before going to the operating room, and a patient who is not only believed to be node negative based on imaging, but has already undergone a thorough EBUS with lymph node sampling, I understand that the nodes all needed to be sampled on frozen section in the setting of a trial. But would it be erroneous to, outside of the trial, presume that the findings are applicable without doing the frozen section if the patient had already undergone an EBUS, still with the understanding that they would need to be sent for permanent pathology just as part of the cancer operation?
Yeah, great question. And somewhere in the protocol, it is clearly stated that the patients who've had a prior EBUS or mediastinoscopy and have those nodes assessed by that method do not need to have the intraoperative frozen section. So yes, absolutely.
That's great. I think that certainly not only does it make it easier to implement these types of results in a setting where we do heavily utilize EBUS in an outpatient setting, I think it actually even makes an argument for folks who say, well, I don't have the ability to necessarily do frozen, or that's going to be time consuming or intense. It may push an even greater proportion of I guess, healthcare paradigms to do histologic nodal staging in advance in an outpatient setting.
Yeah, I agree. I think that would make implementation far a lot easier than it. And
just out of interest,
how long you wait for the frozen section and you get the frozen back, it certainly expedites things for it.
Right.
Yeah.
I mean, the operating room time is the most expensive time, right? And it's time under anesthesia and everything else. So, yeah.
Just out of interest, what was the dropout rate of people that did have N1 discovered nodes and couldn't then proceed to the trial? Do you know?
So there are 5 patients in the sublobar resection arm that were converted to a lobar resection. And there are 8 in the lobar resection arm that were converted to a sublobar resection. And I am not sure what the reasons were. We tried to get the reasons before, but I'm not quite sure. The numbers are way too small to make a statement about that. I'll tell you this. I don't know how many, several years ago, I think maybe in 2010 or something, or 11, we published a paper about what was the most common reason that people who were eligible failed to proceed to randomization intraoperatively. And guess what the most common reason is? Benign nodule. So, and then the second most common reason is cancer other than non-small cell, so metastatic lesion. I think the number of people who ended up having positive nodes in the setting of a negative clinical stage was fairly small.
So just to be clear on that, people were sending the actual nodule off with the nodes as well, I guess, in a vast number. So presumably you're going in and actually wedging it and sending it off with your nodes, mostly, would you say?
Yes.
And then randomization was to carry on or not, I guess, in quite a lot of this.
Exactly. And if you don't have a diagnosis pre-op, you would do that. And if your margins are clean and if you're happy with your resection, then you're done.
Mm.
Yeah.
So yeah, I mean, what a fantastic trial. So just looking forwards, how do you think your trial will influence practice going forwards in the next 5 years? I mean, I personally think it's going to be transformational. We're going to rocket towards sublobar resections, especially in the world of lung cancer screening. But what do you think the implications are for the Altorki study, and what will people be saying in 10 years' time?
I think that just think for a second about the spectrum of patients that we see that have this. Elderly patients, COPD, sometimes pulmonary functions would preclude them from having a bigger anatomical resection? Would a superior segmentectomy, which is now considered to be a compromise operation, be a definitive operation? Would a wedge resection of a potentially complex posterior apical segment be an equally effective operation? And the answer in both cases would be yes. So I see that a larger proportion of patients would be now candidate for curative therapy, surgical treatment. So that's how I see it. Lower mortality, lower adverse events rate, shorter time in the hospital, higher application of minimally invasive approaches. I think, but then again, it's important that to keep it within the context of the eligibility criteria of this trial. We're not saying that, you go ahead and you have a 2.5 centimeter lesion, you do a wedge resection, but we're not saying that. I think that still the standard treatment for that would be a lobar resection.
This is terrific. Dr. Altorki, as was mentioned, we could probably talk about this for hours on end. I think the number of questions you've answered is phenomenal, but you've also raised a lot more questions that we are looking forward to answering for us in the months and years to come. We just want to thank you so much for your time and for sharing your insight and your wonderful findings with us here and the CTSNet community.
Thank you so much, and thank you for giving me the time. And I look forward to our next interview, which I encourage you guys to challenge me even harder on the data. I can see Joel wants to challenge me more, but he's holding back.
Well, I look forward to reading it. Which journal will I be reading it in?
One of the throwaway journals, I think.
You could always publish it in full on CTSNet if you prefer, but
I will keep that in mind. I will definitely consider that as a backup option.
Perfect.
Great.
Thank you so much, Dr. Altorki.
All right, guys. Thank you. Have a nice day.
Bye. Right.